This is a study that will make your hair stand up. Two gentlemen from Johns Hopkins presented this. They said, all right, we have 13 million people diabetics. 1% of this population will develop end-stage renal disease. 1% doesn't seem very high. It happens to be 130,000 individuals. Microalbumin, this was when microalbumin just came out and was available as a point-of-care testing. $20 per test. It's much cheaper now. If I screen the whole population, that whole population of diabetics every year, it would cost $260 million. Oh my God, there's so much money, right? But assume, they said, assume that 50%, according to the medical journals, will respond to ACE inhibitors. That means they will not develop end-stage renal disease because I picked it up early and I put them on ACE inhibitors. If I don't do anything, right, those that get end-stage renal disease, when they go into dialysis, it costs $47,000 a year per client. Very expensive. And it will cost the system $306 billion. Right? But the cost of testing and treating them would only cost me 2.06. I don't mean 300, 3.06. I'm going to save $1 billion if I do this screening. No one's done a damn thing about it. Nobody. No country, Canada, United States, no one. Nobody is doing the screening of end-stage renal disease. Never mind atherosclerosis. Never mind retinopathies. All of those things. It's just there. So my point being is just because it has an economic gain, if you don't have the people pushing it, it's not going to happen. And there's got to be other reasons why people do things. Okay. So we talked about one of the strategies was to get those patients out of the hospital bed. In the United States, everything is based on a prospective payment system, a DRG. So if you come into my hospital and you are diagnosed with a 409 cardiac infarction, I will get $5,000 from whoever, whether you stay there 1 day or whether you stay there 10 days. So as a businessman, what do I say? Bye. Right? Bye. Come in, do whatever I can, and push you out of that hospital, because now I can get another DRG in there and make money. And this is what happened. Look how many beds we've saved in the United States by doing this. We used to have 1,600,000 just about. And this is the number that we've been maintaining, give or take a few thousand, for the last 5 years. So we have managed to push the patients out of the hospital and say, don't stay, we'll fix you and send you home. But the reality is that many of the patients who leave now the hospital are sick and that they need some kind of health care. Yeah. So why do they want to do this? The Medicare charges, or what I can get from Medicare, is $2,400 for the hospital, $523, $93 for home care. If I'm responsible for delivering health for you, and every time I fill that bed with a particular DRG, if I'm averaging $2,400 each time I get a new patient, the idea is to get those patients in the bed and out of the bed and send them home to the least expensive health care that I can give them, which happens to be the home health, which is $93. So what I did is, living in New York, I looked at 440,000 patients, and I tried to figure out where are they going. And I broke them down as far as age. You can't see it over here for some reason. But what happened is there's a lot of individuals, and it increases with age, that are going into the home health care industry. Now, home health care in the United States has done this for many years. It's gone up and down, and people tried to get in it, and they have not been successful. But now I have a lot of people being pushed out of the hospital because the hospital doesn't want them. They want to make money. And they're pushing them into what we call a lower cost health care. And when I looked at them, other than, in this entire population, other than glucose, prothrombin time was the key point of care test that was being performed at home, which means that most of them are cardiac patients. So they're getting bypasses and they're getting all kinds of work on the heart, and they have Coumadin. They have a blood thinner so they don't clot. So they're doing cardiac patients and they're getting them out of the hospital as fast as possible. That's what the indication is. So, now, again, go back, be the government, and I'm standing before you, and I say, oh, government, 1970, we had 70 million home visits. Okay. 1997, we had 301 million home visits. And after I pick the person off the floor, they go, oh my God. And Medicare cost for home care has gone from 3.9 billion in 1990 to 17 billion in 1997. And the Medicaid costs are 10 billion. And the nursing home care in 1995 was 77.9 billion. And the individual required nursing is going to go from 7 to 14 million. And we haven't even seen the baby boomers yet. So the government's going, oh my God, get out of my office. You know, I don't want to hear this, because this is a crisis, no matter where you are and what government you are, is that how do you deal with this issue? It's extremely expensive. So my government, probably very much like your government, they have simple solutions. They said, oh my God, look how much money we're spending in home health care. Let's do a balanced budget act, and then we'll cut what we give them. Okay, that makes sense. And then we save millions of dollars, and then the home health care agency goes, oh my God, microeconomics. How am I going to find profit in this market? I mean, they've taken millions away from me. So look at it. Medicare fees for service, they were approaching $18 million, and after the balanced budget out, they immediately dropped down to $14 million. They also said, another easy way to control costs is, let's make it harder to get home health care. Who qualifies, right? Well, you don't qualify anymore because we have new rules. Right? And how did the home health care industry respond to this? They said, we'll have less visits. We used to go for a cardiac patient 30 times in a 60-day period or a 90-day period. Now we'll go 15 times. And that's how we'll deal with it. So who suffers? The patient. We do, of course. So that was fine. But now the government, I come back in the office of the government and I say, these are my long-term projections for home health care and nursing home. Look at that. We're approaching $161 billion. And they go, oh my God, we've got to do something again because we can't take this. So we looked at it by who's going to pay for this? And I show the government. Well, my indication is that Medicaid in the United States is those that are uninsured. The government picks it up. So the government's paying. And so you can look from this graph, who's paying? Medicare and Medicaid is going to pay a lot of money in the future for these individuals, even though I did the Balanced Budget Act. So how did they respond? Well, they said, I know what we'll do. That DRG worked real fine for the hospital. Why don't we implement something very similar for the home health care group? We'll give them a prospective payment system, and we'll base it on 60 days. I'm going to give you a flat rate now. So when that patient comes out, and it's a wound patient, you will get $1,200 for a 60-day episode of care, and you figure out how to make it happen. Now, I need to tell you this, that HICFA, which is one of the governing bodies of this, we already started to play with telemedicine, and they said, we will never, ever allow telemedicine to enter the home health care industry. We will just not do it. We will not pay for telemedicine. If you want to get reimbursed, you have to send a health practitioner into the home. Okay? So the home health care industry looked at it and they said, well, obviously, we have to manage our patients very good under this 60-day episode of care so that we can, it's microeconomic, so that we can get a profit, because the whole idea of the game is to get a profit. Right? So, what was the key to save money? Fewer visits to the hospital, right? They definitely want fewer visits to the hospital, to the emergency room. They don't want their home health care people coming and saying, I don't feel good at the ER, because that's very costly. Or, I think I should be admitted to the hospital, and they show up at the hospital and they have to admit them. Again, that's $2,400. Connectivity. We need to connect all of this information somehow from the home to the practitioner, to the laboratory, to the hospital, right on down the line. But the point is data. So connectivity is the key. As I said, it was for the integrated hospital model. It is now becoming the same relevance to the home healthcare market, to the ambulatory care, community-based healthcare system. So if you look at what we have now, we have the core laboratory that I was talking about, and we have all the departments that are housed in a typical hospital. There's connectivity. We talk to each other all the time through the IT system. I share information, I get information on the patient, I give them laboratory results, and if I'm in an integrated delivery system, if I have a central repository, or every one of these hospitals, including the core laboratory, have the same LIS system, they can talk to one another and share information and download information, and it works well. The key now is to really go into the community, into the web-based type system, because we're dealing with this aged population. Now, if you take physician connectivity, if you look about where IT is going, where it is now, physicians truly do have access, some of the more sophisticated ones. They can tap into the laboratory and get information. They can tap into the pharmacy, all through IT systems. They can tap into the hospital, to the HIS system, to find out where their patient is and what's going on, those kind of things. But the problem with IT at this point is that it's fragmented. Physicians complain very much that this is not working, and that the retrieval of the data in the system that we have now is labor intensive, and they're not willing to give their time or their staff time to sit there and pull X from X-ray, X from the laboratory, X from pharmacy, what was their last hospital that they stayed in. So it's not working too well. So the next step is to really work on the web-based information technology that we can share from the patient's home all the way to the top of the peak, which is the tertiary care system. Now, if you look at these models as an example, Triple G, patient data repository, where you tie everything into a repository, whether it be an ASP or whether it be a central core laboratory that houses the data, and then disseminate the information in any direction that you want to go. It's very nice. And same with the physicians. You want to connect your physicians into any piece of where their patient had any kind of diagnostic information or healthcare information. It's going to make the system work well, and it's going to be cost effective. Now, home health connectivity. The people who were developing the technology that I'm going to talk about have been on target for some time. They saw this coming. They knew that labor was going to be a major component of the cost in delivering home health care. So this was the first one. This was Kodak. What you're seeing here is what we call vital sign box technology. And then it can be downloaded through a phone line, through a TV cable, to any physician, any practitioner, laptop, anything. And at the same time, you'll see that there's a video camera on each there, that the patient in the home and the clinician can see one another. So this is face-to-face piece. This is what the earlier technology, we're moving beyond this now. Now you have to realize this is sensor technology. There's no reaction taking place. All of the data that's being transmitted via the lines is just signals. So there was no problem getting FDA approval because we were not doing any kind of test. We were just moving signals from the body into another repository, touch and play. So heart rate, blood pressure, O2 saturation, weight, temperature, plus they have a connection for a spirometer or any point of care testing that you would want to do. So now the diabetic could really sit there and just generate data and send it to wherever they want, to the laboratory, to the physician's office, to anyone that, or all of them that they want. So, now, go back and be the home health care industry administrators. A full-time tele-home care nurse can make an estimated 14 to 16 home visits per day using telemedicine versus 6 to 8 when they actually go to the home and see the patient. Big difference. So I broke that down based on some national statistics. An RN gets $90 for a visit. If they do 6 to 8 for me as the administrator, I have to shell out anywhere between $540 and $720. If I pay an RN $77,500, which includes their fringe, right, which comes out to $310 a day, I can get them to do 14 to 16 visits using telemedicine, and now I average out at somewhere between $22 and $19 per visit. Big cost savings. So the home health care industry is looking at this with open arms. Please give me all this technology, because the technology is not that expensive. The technology in the small communities that they're doing now is averaging about $5 a day. But as the industry grows, it will become less and less and less. So, and again, the industry has now said you can go ahead and use telemedicine, where they said that you weren't, because they're not reimbursing it. What they're saying is that you get a 60-day prospective payment fee, and how you take care of the patient is entirely up to you, long as it has the physician's approval. So when the physician saw that the nurse can see the patient and the patient can see the nurse, and that this data is going back and forth, the physicians blessed it. So where they used to go out 20 times for a visit, they now go out 4, and the rest is all done by telemedicine. So it's really changed the economics. So the first one that came out, the home med, this is really where it's at. This is really the economic impact. They had 4 beta sites for 8 months. 97.6% compliance with the vital sign technology monitoring as compared to 30% when they used the phone. That's incredible, because compliance is a key in the management of any patient, whether it be a congestive heart failure, whether it be a diabetic. Compliance, 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 because if the patient is not doing what they're supposed to do, they're going to get sick, and they're going to end up in the healthcare system costing us a lot more money. They reduced the emergency visits by 87% and hospital encounters by 90%. And those that were admitted had a decreased length of stay because they had the data on the patient, and they quickly got that data and made a decision whether to keep the patient or bring them back home. So think of it as a patient. If you leave the hospital and for the first time that you've known that you have congestive heart failure, and you go home and your heart goes flitter-flatter, you get nervous. Any person would. So what they do is they run to the ER because they don't have anyone to talk to. But if you have, as we're seeing in the study that we're doing, they just hit a button and a red light goes on at the nursing station in the home health care industry, and they just bring the patient up into view, and they have a conversation. Put your finger in the port, let me see your pulse, get the blood pressure cuff on, boom, boom, boom. They make a decision. You do not need to go to the ER. Okay? And it seems to really satisfy most of the patients. So the costs have gone way down. What are the economic benefits? Kaiser Permanente, they did a 1-year study with 200 patients, which include cancer, diabetes, cardiac, lung disease, and they found that they could reduce the costs by 1/3 by implementing this kind of technology. The US and the UK discovered that 45% of the home visits could be performed by telemedicine in their study. And the average cost of the face-to-face, and this kind of is obvious, we just talked about it. But this is the big one. This just came out September, October issue. And it was a study done, the Veterans in the United States is a big organization. We have many hospitals, we have many clinics. And what they did in the last few years is they've broken them up into regional clusters. And this happens to be one of them. And it's the Florida, Puerto Rico, Georgia area. So it's elderly people, and it's a very warm climate, so that a lot of the veterans go down there to retire. So of the 734 patients that they had that qualified under this, 60 of them actually went into the study. 600 of them, sorry. And again, you can see diabetes, hypertension. But they found, using this kind of technology, they decreased hospitalization and the ER visits. They decreased their medication costs. The average cost prior to using telemedicine for each of those patients was $58,000. And they cut it down by almost 75% using telemedicine, where they saved $23 million. It cost them $2.9 million in an investment to set up all this software and the hardware in the homes and to do the educational programs and to set up administrative sites that would do the monitoring and that where the home healthcare people could talk to the nurses or the physicians. $2.1 million is a lot of money, but they saved $23 million. And this is just a small segment of the population. And then we can just go on. The economic impact of home health care on asthma and ventilators. Again, you can see that the literature is just full of the impact that this can have. I wanted to do the psychiatric one. Now here's the psychiatric one, 2-year home. This is a 2-year in-home crisis intervention program. And you can see the outcome from here. Their length of stay reduced from 11.97 days to 7.48, and only 11.8% of the home health care patients were readmitted compared to 45.9% of the patients who did not receive home care intervention. Right? So it has a major impact. So what I'm saying is that this industry is wide open, not only for the additional pieces in biosensor technology, but think of the data collection and the repositories that the governments and the home health care agencies and the managed care organizations can do on the population as they begin to age. It's just all raw data, and they can look at what is the best way to manage the patients and do all these great things. So this is what really should be taking place in the next few years, is that you should have this connectivity between the patient who is sitting in their home to the physician, to the hospitals that they've been in, right on down the line, that there should be complete connectivity all different ways. And trying to stay with informatics, the last piece I'll talk about was connectivity is very important, but the physicians that are out there and the clinicians, because we're using nurse practitioners and physician's assistants a lot more in our industry because they're cheaper. What they need to do is to make better decisions based on the data that they have. And they don't necessarily have that data or even the knowledge base. They're overwhelmed. At least in the United States, the Medicare have pushed them with the paperwork and fill this out and you can't do that test and those kind of things. But there is an outfit in Australia that have a software program that looks at the laboratory test and helps the physicians make a wise choice. And I just took one of their slides to show you. Now here's some laboratory data that was generated on a patient, and the company is PKS. And you can see on the bottom, now this is a note that came from a pathologist just as a recommendation to the physician to help him or her better manage this patient. No significant change in the hemoglobin A1C. The diabetic control remains poor, that they really should consider checking urinary microalbumin, because now they're saying that if you can't control the diabetic with the insulin, then you have a problem, and you really have to start to monitor the patient for end-stage renal disease. And so it's an indication of what's to come as far as data management of the patient. So it is my belief, really, that in order to make the community-based healthcare system work, you need to provide healthcare providers patient information. You have to have connectivity. You have to standardize the protocol within the community. You have to have easy access for the healthcare providers to the patient database. Telemedicine, evaluate the outcomes. Is this working? If we're doing hemoglobin A1Cs on the diabetics in our community every 6 months, is that better than once a year? Those kind of decisions can be made, and that's what I mean by the raw data that's coming from this kind of technology. Because if we develop the tools to separate it out and to make better decisions about the management of the patient, the better it will be. And I'll end there. Okay. Yeah.
So, starting point, any comments or questions? Anybody brave?
Isn't the next logical step that perhaps you don't even need the doctor either? Or,
well, the physician's role, I think, will change very much. We have, at university hospitals, we have nurse practitioners, which we train, and we have physician's assistants. We have family practitioners, the MDs. And we have a difficult time finding physicians to go into family medicine because it doesn't pay very much, and managed care has driven it to be a real paper-driven area, so they don't make a lot of money, and they're really considered among their peers as a very low-level physician. So what's going to happen, I think, is that there are going to be very few of them, and that the people who really look at this type of population, the chronic ailments, are going to be the nurses, the physician's assistants, and the nurse practitioners, which makes sense because that's what we did in the laboratory. We took away the PhDs in the community-based laboratories and hospitals and put them in the tertiary cares. So what we're going to have is physicians who are high level. There's not going to be as many of them, but the general procedures that take place when you feel sick and you want to go see a physician, you're probably going to end up seeing a lower level individual. We're seeing that now in the States. I mean, at this point now, we can, if you don't belong to a managed care and you have another type of insurance, you have the option whether you're willing to see a physician assistant, a nurse practitioner, or the physician themselves. And more people are saying, well, I'll see the physician assistant or the nurse practitioner, because they feel, see what they do. The difference is that the PA and the nurse practitioner is allotted more time with you than the physician themselves, because time is money. So they feel more comfortable, because most of the time, as we're all lucky enough, when you go see a physician, it's either for a physical, or you got the bug, or you got a cold that won't go away, or something simple. And the whole idea of the process is that if the provider at that level, in their scope of practice, sees something that they're really not qualified, they're supposed to move it up to the level that the physician comes in and sees you. So, yeah, we're taking what we know as the physician out of much of healthcare as we know it, for routine healthcare. Yes?
You had one example where it was obvious that if we did this simple test over a great huge population, it would save lots of money, but it's not being done.
Right.
Do you have any suggestions how to trigger that so we
That's a tough one, because I've asked this question many times, like, why do not managed care organizations in the United States do screening tests of their population? And they will never say it openly. What I've been told is that if you're my patient and you're 10 years old and I screen you and I find out that you have a hyperlipidemia, so you have a high elevation of lipids, and genetically you're prone to cardiovascular disease, and that you'll probably die around 50. All right? But, yeah, goodbye is, I hope you leave my system. But however, if I invest educational program and the time and energy to show you that by doing this, you'll add 10 years to your life, but the chances are in the United States, at 10 years old, that you will not be in my district when you're 25. So I invested all this money into this young lady, and now she's left and who's going to benefit? My competitor. So that's why they won't do it. Economics. Yes, sir.
What is your view about making the information more transparent to the patient? For the moment, of course, there's really a black wall, a very thick wall between the patient and the information, because the doctors is the only one that can release this information.
That's changing. We have what they call HIPAA in the United States, who's looking at this very carefully. But there are a lot of states now that are allowing the patients to order their own tests. They can show up at a lab and say, I'd like the cholesterol and an HDL and an LDL, and they can have that information sent to their home. We've always had the option that patients can, the freedom of information, where they can go in and get their medical records and look at them. The web is a very interesting piece, because every time that I talk about this in the United States, that's what I expect to hear, is everybody jumps on me. They're going to look at their data. Oh my God, that no one's ever going to put up with this. But what data do you not want to show? That is the question. If I'm doing sexually transmitted diseases on you, you definitely want to keep that a secret, because I don't want to make that a public issue. But if I'm doing pulse and blood pressures and stuff like that, the only one that you probably don't want to see it is your insurance company, for the same reason that bye. All right? That's the only thing that we find that patients are concerned with. Very privileged information as far as those kind of diseases, but they're afraid of the insurance companies dropping them based on. I mean, that's the whole thing with genetics. I mean, that's why people are saying genetics is not going to go anywhere, because if my family is prone to cardiovascular disease and it's known through a genetic typing, how are my children going to get health insurance? Because the health insurance is going to say, hyperlipidemia, or $10,000 a year if you want insurance. So it's a problem. But the type of things that they're doing in home health care is really not high-level diagnostic information. And most patients feel, because of the firewalls that are put forth, that most people won't get to them. And that's going to change. You know, they're trying to set up websites where you can actually deposit your records, and you're the only one for your iris can get into it. Those kind of things.
Unfortunately, we're at the end of the time, and if you would like to come down and talk, I'm sure we'll be here for a few more minutes, so I'd welcome your coming down. I want to thank all of you for coming, and I look forward to seeing you again in January. Have a good holiday. You have some things to say, Don?
Well, I do. I want to thank our speaker for coming today,
okay.
and here's a small token of our appreciation.
Thank you very much.